one big question is, what is the difference between palliative care and hospice care?
True comfort-focused care.
A younger gentleman, but he wants to try one less immunotherapy.
And you said, hey, you need to choose a hospice.
And open up a hospice business to become a millionaire, it's probably the wrong business.
All hospices are the same, so just pick a list. Tell me what makes a good hospice.
The medical social worker on the team, I think of it as almost like coordinating the patient's care from a different perspective.
Welcome back to the LifeChoice podcast. Today I'm joined by Iona, our administrator at LifeChoice Hospice, and Sarah, our social worker. And today we're talking about some myths in hospice. One of the biggest questions we get on a regular basis, people calling in, they get a doctor, or maybe they're at a doctor and they're saying, hey, you need palliative care. We go in there and start talking to the client. And one big question is, what is the difference between palliative care and hospice care? So I know you do a lot of goals of care conversation and you're meeting with a lot of our patients. So I'll hit you first, Iona. What is the difference between palliative care and hospice care?
So I would say the biggest difference is how I describe palliative and hospice is palliative is a bridge to hospice. So there's two different cases that we see usually with families. One to where somebody is clinically hospice eligible, right? Let's say they have terminal diagnosis like cancer, for example, right? But they're not, it's more of a family than the patient, but they're not mentally there yet. They are still dealing with the fact that they have a terminal illness. So, palliative care would be more of goals of care conversation. The other aspect of it is somebody who is mentally there saying, I've been in and out of the hospitals multiple times. I am older. I don't want to do that. I want to be comfortable. I want to be home. But clinically, they don't have enough going for us to qualify them for hospice. So I would put in both of those kind of different buckets. But so palliative is more goals of care conversation. There are some cases to where we do help manage some of the symptoms. For like cancer patients, they might have effects of like radiation or they're not feeling good. So we're coming in there as consultants to help them manage those symptoms. With hospice, it's comfort care. So we kind of take over the care for the patient. We manage all their medications. We make sure that, not only that their symptoms are managed, but their families also supported.
Let's stop there real quick because I just want to make sure that, everyone knows, Sarah, from your perspective, it is to me the biggest thing is the support level. So
Absolutely.
Maybe walk through difference of palliative support versus hospice support.
So they're very different in terms of the level of support that they can provide. We do find that most patients who are seeking true palliative care services it's usually done at the same time as oftentimes like home health, right, and palliative care. Maybe patient still wants to see if they're able to meet goals to improve their condition. Maybe they still want to see, multiple specialty physicians. And someone who, is receiving hospice services, that's true comfort-focused care, working to manage symptoms at home.
Perfect. And then, so as we're doing that, do we find, or do you all find, a doctor may say palliative care, and what we find is because they don't know how to have that really long-term hard conversation of, there's probably something happening and you need to have a goals of care conversation. Yeah. So they're going, hey, we get many of our referrals. Hey, it's palliative, but it goes into hospice. Yeah. Maybe walk through that process for, the people viewing today. Like, when should we have that conversation? What should you be expecting on palliative versus hospice conversation? Start with you, Iona.
Yeah, we do get a lot of phone calls like that, right? My physician recommended palliative. I want palliative. So, okay, well, again, we're starting with that goals of care conversation. So we meet with the family, and that's where you really kind of break down of what do you want, right? What are your goals? What does that look like for you, right? Quality of life. What do you want to take place? And I think guiding through that conversation, I think patients and families come to their own realization like, okay, they say palliative because hospice word is so scary. But when you go through what are the services, what are your goals, they're like, yes, I want the nurse to come here to manage my symptoms at home. No, I do not want hospitalization. Yes, I want to sign a DNR. I want to spend the rest of my life with my family and loved ones and not go to different doctors. And I just want one care team of people to take care of me and be my first point of contact. And I think people come to that realization. They said, oh, well, yes, I actually want hospice. That's the service that I want. But I think why they get recommended palliative is a lot of people are not equipped to have that conversation, right? So I feel like when physicians are not sure how to talk about hospice, but they know the patient needs some symptom management and maybe there are some goals that more align with hospice, they kind of say, reach out, ask about palliative because they trust us to have that conversation.
Agree. I think, doing a palliative care consultation is an excellent opportunity to have a goals of care discussion to really understand what is the goal. Knowing what the goal is through discussing this with people is going to guide us in what care option is going to be most supportive.
Yeah. Sometimes it is palliative because, we have multiple people on our palliative services right now that, let's say, I met with one last week. Perfect example. He is, a younger gentleman, but he wants to try one less immunotherapy. Yeah. And he said, I haven't been feeling good from the last ones, but, let me just try this one. And if I don't feel good, then, I understand there's no treatment for my disease, but maybe this will help. And we say, okay, then, we're going to add you to our palliative program. We'll be there as your consultants, as your support, and kind of guide you and be there for you. So sometimes it is palliative, but a lot of times I think those goals of care conversation is comes out of those palliative consults, and people realize, well, I want higher level of care.
Well, and I think, one of the misconceptions of palliative, especially with a lot of facilities or doctors, you're on palliative care, well, they're, going to send maybe a nurse practitioner, a nurse, you can have some social work, you can have some chaplain services, but I feel like it's very minimalized on most palliative programs because naturally the payment's not really structured. The only one getting paid is a nurse practitioner. So a lot of it just depends on what hospice you use to figure out what they're going to do. Is it phone visits? But it really is the difference of knowing palliative gives me a minimal set compared to hospice gives me this whole support team. So maybe, Sarah, talk a little bit about the support team. If I signed up on hospice or signed my mom on hospice, what team members am I able to get?
Yeah, definitely. So I think we can kind of start with the patient's attending physician. I think there's a myth out there that says when someone is admitted to hospice that they can't continue seeing their attending physician, and that's just not true. I think in some cases, maybe if their attending physician hasn't seen them in a long time, they might, not continue to follow the case. But in those cases, our medical director could take over. A patient's attending physician can absolutely be part of the care team. We have our own medical director who, is available to us 24/7 for those cases when, the nurse out in the field needs, to speak with the doctor. Maybe, we need to go up on the patient's medication. Maybe we need a new medication. So the nurse will reach out to the doctor, consult with the doctor, and see what else might be needed. And of course, discussing that with the patient and their family to make sure that they're in agreement with that. Then there is the registered nurse case manager. So the nurse case manager, think about them as really being the eyes, ears, and hands of the doctor out there in the field, visiting with the patient. We say that how often the nurse will visit is just based on how the patient is doing from day to day and week to week. This can change all the time. You're having a bad week. It might be extra visits that week. You might have also on-call visits, and maybe the next week you're feeling a little bit better, right? So it's not set in stone to say, well, once you start out with this number of visits, it never changes. It will change to meet the needs. There is a CNA, so a certified nursing assistant.
So CNAs, they certified nurse assistants, like Sarah said, and they're there to do bathing and showering, help with hygiene. They're there to maybe it's feeding, maybe it's painting somebody's nails, maybe it's doing their hair. They're there as another level support for mostly the families and the caregivers. But again, they're following nurses' orders because how many times are we going to bathe the patient? What are we going to do with the patient? What is the patient diet, right? If they are there to feed them, right? So they have to follow certain orders based on what patient needs are. And then
And I think one of those big things that I think a lot of people miss, they're the ones doing a lot of the hard work and really being another set of eyes for the nurse. Because a nurse may focus on medications, but a CNA is going to be able to say, I see a wound, or I see this redness, or I'm just seeing them not wake up as much, or not alert, or hey, they're forgetting a lot. So maybe...
So CNAs are the eyes and ears, right? They spend most of the time with the patient, but also they spend the most intimate time with their patients, right? Mm-hmm. They're the ones who are bathing them and showering them and, seeing them naked. Yeah. And there are sometimes there more often than the nursing staff is, or social worker, or spiritual care. Yeah. So they are truly the team member that builds the most relationship with the patients. And because they're more often, and they will report anything, any changes they see to the nurses, and they're that kind of bridge between the clinical need and the family and those communicators. So they play a very vital role in our...
And you mentioned a couple other folks that are going to be in there. And Sarah, you being a social worker, let's talk a little bit, again, social worker and chaplain are another two support groups that you get when you get on hospice that are there for you. Maybe talk a little bit about those since you're over that program.
Sure. So the medical social worker on the team, I think of it as almost like coordinating the patient's care from a different perspective. So this might be, meeting with a patient and family and identifying issues or maybe things that will come up potentially in the future and working to resolve those things, right? So this might be something like, of course, advanced directives like we were just talking about. This might be, meeting with a patient, doing an assessment and realizing, the patient has an estranged relationship from their child, right? And this is something that really seems to be bothering them. Is there anything that we can do with this to help provide more comfort for the patient? This might be knowing that a patient is living alone and the patient is decisional and they are, very intent on staying home as long as they can, and that's their choice, right? As a social worker, I might look at that case and say, okay, we're here right now, but looking to the future, what do I need to put in place? What kind of conversations do I need to have at what point in care to kind of get us to where I think we're probably going to need to go at some point or another, right? So I'm thinking, is this patient a veteran? Who are the supports? How are we going to pay for this? How are we going to? There's so many questions that kind of goes into it. And as you're doing these visits with the patient and the family, you're constantly working at it. And it might be bit by bit by bit, but slowly we want to make steps towards that.
And I think we're going to have another podcast solely of what a social worker does, because there's so many things, helping with funeral arrangements. Maybe go a little bit into, what does a hospice chaplain do and what makes it a little different than a social worker?
Yes.
Or a lot different.
So hospice chaplain will be there to provide spiritual or religious support for a patient, regardless of their faith base, to make sure that aspect of their life is honored and that the patient receives the comfort that they want to, if that's something that is important to them. And the chaplain can also connect a patient with a local clergy person from a church or whatever it is, another religious institution, if they have a very specific connection to that. That's also part of their assessment. And they're certainly there for the emotional support piece of it too. I think especially for patients who do have a very strong faith base or connection to spirituality, as patients get closer and closer to passing, that support can be incredibly important.
In a few other positions that many people don't talk about, volunteers. And again, it's a percentage that you want to hit according to Medicare, but really having volunteers as well as there's just, the whole team around hospice. Is there anything else that we're missing that says, when you get hospice, you get this other support?
I think we should talk a little bit about volunteers.
Of course.
I think they're incredibly important. Volunteers can do things that regular staff members oftentimes don't have the time to do. And that might be, a volunteer going to sit with a patient. And I have volunteers who have played cards with patients. They've, helped them write letters. They have wheeled them outside when it's a nice day, allowed them to get some sunshine on their face. I've had volunteers who met with a patient and the patient is, starts to decline and they really start to begin the active phases of dying. And the volunteer has brought meals to their family and just done incredible things that maybe weren't even required that they do, but they do it out of the goodness of their heart.
And there's amazing things like, we have some volunteers coming in and just want to give presents to families. Hey, we have a little extra money this year. Mm-hmm. Let's pick 5-10 people. Let's, help them write a book or, help them just put their thoughts onto putting their families together. So I agree, having a good volunteer team mm-hmm. is amazing. But maybe, Iona, you're able to really look at us and say, because there's a lot of myths out there. Hey, once you get on hospice, you don't get this. But like different therapies, there's physical therapy, occupational therapy, music therapy, pet therapy. These are all things that with hospice, there is a big gambit of things if that's what the patient requires or needs. Like we try to throw that out there and say, what do you need? So maybe walk through a little bit of those. Again, maybe not home health that they're coming in 5 days a week, mm-hmm. but it really goes into that goals of care. So maybe talk a little bit about that.
Yeah. So I think one of the barriers, especially when we're talking about patients who currently had hospitalizations and had experience with home health or just had their primary care physician order home health, whether it's for speech therapy, occupational, physical therapy. So one of the barriers is like, well, once I go on hospice, and myths, right? Once I go on hospice, I have to stop all the therapies. Well, you might not be getting therapy through home health, but we still provide that, right? So going back to the goals of care conversation. So for somebody who's been getting, let's say, physical therapy, right? What are our goals of that physical therapy, right? Is our goal to have somebody start, walking or running, right? Or is it our goal is to maybe do some strength training so they can pull themselves up in the bed? And that's something we can still provide. Our CNAs, for example, they're there with patient, a lot of more frequent than any other disciplines, right? They can do the range of motion with the patient. So I think it's understanding what the patient needs, but all those things we can also provide. We have pet therapy. We offer music therapy. So those are one of the other things. So if somebody, if we get a patient and they were a guitar player, and that was actually kind of how our music therapy came about, they were a guitar player, and it was very important for his wife for somebody to come and play guitar. And that was one of the first things that she asked when she called, do you guys provide music therapy? And so we provide music therapy. So there's a lot of things that, there's a lot of myths of like, I have to stop all these things, all these therapies and all the things that, like music therapists coming out mm-hmm. When I'm on hospice. And that's not true. Because we want to provide the best quality of life for the patient, whatever that means to them. And if it's having pet therapy, music, or maybe some strength training or exercise with the nurses, that's what we're going to do.
And I keep hearing the word myth. And I feel like there's tons of myths about hospice. Yeah. One that I really want to say is, that the doctors on a regular basis, they give a list, or maybe you're at the hospital and it is time, and you said, hey, you need to choose a hospice. Here's a list. Pretty much all hospices are the same. So just pick a list. Tell me what makes a good hospice. Like, are they all the same, or is that a myth, or is that true?
Yeah, so I don't think they're all the same. I think that by insurance, yes, hospices are receiving the same money from the insurance, right, to provide these services. I think what defines a good hospice and maybe a hospice that, isn't as good might be, how they're spending those dollars that they are getting, truthfully. I think that, it really should be personalized. And I think that that's unfortunately a term that's kind of been overused in the industry. But I think the core basis for personalized care is absolutely true. Maybe it's more important to a patient that, who has a caregiving issue to have more CNA visits at home, right? Maybe it's more important to a patient who has caregiving services at home, but doesn't have, a lot of family support, right? And they, maybe they were a musician. Maybe they would benefit from some music therapy visits. It's really knowing what is important to the patient, what's important to the family, and how do we, what are the services that we're going to be able to give them to, to provide them the most comfort.
Completely agreed. I mean, I think that's a good point as far as, all hospices, Medicare pays the same. It's capped. You can only get so much money per patient. And like I said, what do you do with it matters. What I think, and we have people ask all the time, like, what makes your hospice better than others, right? So, because there are a lot of companies. I think it's how you spend the Medicare money, and our people in that hospice agency are there for the right reasons. And the reason why I say that is if you are in hospice and open up a hospice business to become a millionaire, it's probably a wrong business. And Alex, our owner would say the same thing. He's like, well, this is where we go into that business to care for people and have them have the best experience and provide them the best care that we can, a genuine care. And I think that's what makes hospices kind of stand out. Because if you have good intentions, other things kind of come naturally in that business. And that's how, I think the entire team, and that's how Alex kind of leads the company too, of that belief, like, we have to do the right thing. We have to do it right by patient and do our absolute best. So I think that, having the right intention, also be, spending money appropriately, right?
It's not just a visit. It should be about so much more than just making the visit to check the box. It really should be about, truly showing someone that you care. And how do you do that? I think that's very personal from patient to patient, but families notice. They will know right away whether you care or you don't. And I think that really does make the biggest difference.
And I think that absolutely. And again, if you portray that, right, as an owner, as administrator, as CEO, as, anybody, right, if you portray that to your staff, and those are the people that you have in your company, you will get that. But, at the end of the day, though, now day and age, right, so like 10 years ago, nobody would look at like reviews, for example, right, at companies, or reviews for primary care physician or cardiologist, right? It would be more like word of the mouth, or who the hospital discharged you with, or their recommendation. And now day and age, when people call us saying, how do I know that you guys are better than somebody else? Or how do I do my research? And I said, that's exactly what you do. You do research. You look at the reviews. You look at, what people are saying about that company. Maybe 10 years ago we didn't have that, but now we do. Everybody leaves reviews from restaurants to hospice to PCP. And those are genuine reviews. And I think, I had a few people say, well, I can go and leave a review for my own company. How do I know they're true? Well, Google regulates them pretty strictly. So we can have 10 people leave reviews, but only 8 will go through. They have their own algorithms, so you can't really fake that. And I think that that's something that people need to realize. But I always say you have to do your own research. Have your own judgment on who you want to go with and interview people.
That's great advice. And as you said, it's regulated, but when you can just get a 5-star product on Amazon and there's 55-star, but there's no reviews of like what actually happened. But when you can go in and say, let me read what people are saying. And again, not all reviews are going to be perfect.
Right.
No company is going to be spotless. But when you can look at that and say, what are predominantly people saying? Oh, they're mentioning nurses' names. They're telling me about the care. They're telling me about their family member in the review and how they were taken care of. It does mean a lot. So again, a great question. Definitely want to hit some more myths, as we progress along. Thank you so much, ladies, for joining me today. Been some amazing content to really answer some of those questions. the myths, the goals of care. So I just want to say thank you so much for being here today. I really enjoyed it and look forward to next time.
Thank you for
Thank
having
you.
us.